I offer my humble salutations at the lotus feet of Bhagwan Sri Sathya Sai Baba. Jai Sai Ram everyone. Our presenter for this month's health webinar is Mr. Gurudatt Sisodia. Mr. Sisodia is consultant orthopedic surgeon specializing in knee and hip surgery at Manchester University NHS Foundation Trust. He provides expertise in reconstructive and repair surgery for sports knee injuries, treatment of arthritis of the knee and hip, as well as general orthopedic trauma. Mr. Sisodia is also an honorary senior lecturer at the University of Manchester for medical students. He is a Joint Region 5 healthcare lead. He attends Sai Centre of Greater Manchester. I'll now hand over to Mr. Sisodia. Jai Sai Ram.
Thank you, Vasanti Aunty, for the introduction and for everyone for joining in the talk and tuning in today. Some of you may have been expecting a webinar on healthy aging, but due to unforeseen circumstances, there has been some changes. So this evening, I'm here to hopefully give you an insight into a topic that's related to aging, and that is arthritis, particularly what osteoarthritis is of the knee and the hip, and how we can manage it. So just to reiterate, I'm a consultant orthopedic surgeon, as Vasanti Aunty said, based in Manchester. So my main specialist areas are involving the knee and hip surgery. I perform joint replacements, so knee and hip joint replacements, and I do sports knee injury surgery, so reconstruct ligaments, cartilage and meniscal repairs, keyhole surgery, that sort of thing. And I teach medical students as well that are coming through their musculoskeletal block medical school. So what is arthritis? Well, the actual word means inflammation of the joint, and it's actually the most common cause of disability in the UK, affecting up to 10 million people. It can be quite a difficult condition to imagine what exactly is going in arthritis, but you can think of it like as though it's a swelling or a bruising that's happening inside that part of the body, rather like not the normal healing process that happens after an injury. You get the body's blood flow increasing to that area, various inflammatory markers and cells moving in, and that can cause typical features of joint pain, swelling and stiffness. And it can affect a number of different parts of the body. The hands are commonly affected, the knee, the hip, the neck, the spine are probably the most common, but it can affect any joint that has what we call a synovial lining. There's also a number of different types of arthritis. So osteoarthritis just happens to be the most common type, and that's a degenerative type of arthritis. Inflammatory arthritis is another group of arthritis, such as rheumatoid arthritis, which we'll talk about as well. Another type is crystal arthritis or arthropathy, like gout. And then there is another type of arthritis that you can get resulting from an injury. We call that post-traumatic arthritis. And finally, there's a septic arthritis, which is due to infection of the joint. And that's a fairly rare but serious condition. So in terms of inflammatory arthritis, rheumatoid arthritis and psoriatic arthritis are probably the more common examples. And this is really an autoimmune process, which means it's where the body's own immune system attacks the soft tissue, particularly those around the joints. So the inner lining of the joint, the capsule, the ligaments, the cartilage, and eventually it can even result in destruction of bone and joints and severe deformities. You can see here on the left-hand side of the image, there is a lady's hands are quite deformed, and that's because the small joints of the hand, which are quite commonly affected in rheumatoid arthritis, have become permanently disfigured and destroyed, and the soft tissues are therefore causing a joint to gradually almost dislocate. On the top right there, you can see patches of psoriasis, and that's commonly associated with an inflammatory arthropathy, arthritis that occurs in the joint as well. And this lady, another lady here, whose finger joints have been gradually disrupted by this process. But the good news is that although it can be a serious condition, over the last 15 or 20 years, there have been some revolutionary medications that have been around and developed, and that can be provided by rheumatologists. So it's really important to be investigated and diagnosed and potentially treated earlier rather than later to try and prevent those debilitating deformities and permanent damage. And the key feature of inflammatory arthritis is that it tends to be worse at the start of the day. There tends to be a significant amount of swelling that occurs around the joints with warmth, and it tends to be a symmetrical pattern. So many patients, as shown in here, have most of the small joints in their hands and wrists and even elbows affected, both knees, both hips can be affected. Whereas other forms of arthritis tend to be more localized. Gout and pseudogout are two types of crystal arthritis, and you might be surprised to learn that crystals can actually be deposited inside the joint. And this image here shows actual crystals that form during an episode or an attack of gout. And as you can imagine, it's an extremely painful condition, probably one of the most painful types of arthritis there are. Most commonly affects the big toe joint, but it can affect the knee. And typically it causes this severe redness, pain, swelling, which is fairly sudden onset in nature. And therefore it can mimic some of the features of a septic arthritis condition, but usually patients well in themselves, whereas with the septic arthritis, they can be really quite unwell. But both kinds of patients present themselves, as far as we're concerned, sometimes to A&E, where we can assess them. The risk factors for the gout or pseudogout are thought to be generally related to lifestyle. So excess alcohol intake, obesity, high purine diet, which really just means high content of certain types of protein in the diet, typically meat. And therefore, the management of the condition is about trying to prevent the disease, making lifestyle modifications. So cutting out alcohol, reducing or cutting out meat if that's something that you take. There are also some medications like allopurinol, which is probably the most common type of preventative medication that is prescribed for these patients. But it's not to be taken during an acute flare-up, because it can make it worse. The other cause can be dehydration. So having lots of water intake, but also natural fruit juices, particularly cherry juice, is something that's been identified as helpful, rather than artificially sweetened juices. During an acute attack of gout, there are some strong anti-inflammatory medications that are thought to be helpful. This picture at the bottom right is what we call a gouty tophus, and that just describes this calcium being deposited around the joint, and that's a chronic feature of gout, which sometimes needs to be addressed by an operation to remove those things. So osteoarthritis, this is to be seen as a degenerative process, as I mentioned. It's a process that gradually gets worse with time, a condition that gradually gets worse. And it affects most of these, it can affect any of these synovial lined joints like the knee, the hip, any of the joints that you'll be familiar with. And it can be seen as a wear and tear type of arthritis, wear and tear of the cartilage that coats the ends of the bones within the joint. And you can think of it rather like how the tires in a car wear down with time. That's not to say wear and tear of cartilage is the normal part of aging, but it's rather the same pathology. And so there's progressive loss of cartilage with time, and there's also quite a significant part of the disease is inflammation that happens as a result of that wear and tear. So on a microscopic level, you get inflammatory mediators or inflammatory cells moving in, causing inflammation, and then a further damage to the cartilage. It's the most common type of arthritis here in the UK, and most commonly affects the knees, the hips, the hands, the spine, as we've mentioned. In terms of some of the figures, it's thought to affect more than 8 million people in the UK and is the most common cause of disability here. As you can see from this graph, the prevalence graph, it shows that patients in their 70s and 80s are the most common type of patients that are affected by the disease. But it's not necessarily exclusive to this age group. You can see how from the age of kind of mid-40s onwards, the prevalence increases quite rapidly. So there is something to be considered there, that it's not necessarily, some people often just associate osteoarthritis with aging, and it's not necessarily a part of normal aging, but it's true that as you get older, the chances of having it are higher. It's more common in women than men, and it's the most commonly affected joint in the body in terms of osteoarthritis. And just going back to that previous slide, this map of the UK just shows the the prevalence of osteoarthritis. So it seems to be more common in terms of the way that the darker colours are in London, in the West Midlands, Northern England, is also in Scotland and in Northern Ireland. I think in order to understand osteoarthritis better, it's best to try and appreciate what the normal hip and knee joints are like. So what are they made of? What do they look like? So the hip joint is a ball and socket joint, and you can see here at the top of the thigh bone or the femur, there's this ball-like structure, which is what we call the head of the femur, and that's covered in this nice glistening cartilage surface. And on the opposite side of that, you have the acetabulum, which is the cup or the socket, which the ball fits into. And the inside of that is also covered in this nice, clean, pristine cartilage. And both together form a nice gliding surface normally. In terms of the knee, this is a different type of joint. It's rather like a complex hinge. So you have the end of the thigh bone or the femur and the top of the shin bone, which form the main joints. And each of those surfaces are lined with the cartilage as well. But additionally, you've got this kneecap or the patella in front of it, which acts like a fulcrum and helps the forces to be generated by muscles like your thigh muscles, your quadriceps, to be even stronger. And the back of the kneecap, the patella, is also covered in cartilage. But it's also got, the knee has also got some important other structures like ligaments. You can see here the cruciate ligaments, which cross each other in the middle of the joints. And then you have ligaments on the sides of the knee, which help the knee stability as well. And if we have a closer look at this picture on the right-hand side, you can see again how the cartilage, the white colour, coats the end of the thigh bone, the femur. The same cartilage is beneath this blue structure here. And this blue structure on either side, you've got one on each side, is called the meniscus, and that's a cushion or a shock absorber that sits over the cartilage, one on each side, and it helps to protect the cartilage from damage on a daily basis. If you have damage to the cartilage, to the meniscus, then you can imagine how the forces that pass across the joint can cause some damage to that cartilage. If we zoom in a little bit further and look at this photograph that we take during keyhole surgery, we can see how on the top of that picture you've got the femur, or the end of the thigh bone, which is covered in this nice ivory coloured cartilage, which is relatively soft. Likewise, the tibial cartilage, and in between you've got this nice perfect meniscus. And together they form the ideal surface, a bit like ice cubes. If you imagine two ice cubes rubbing together, that nice, smooth, gliding surface is how I'd kind of describe the knee joint. And if we look even further at on a microscopic level at the structure of cartilage, it's pretty amazing and a complicated structure. It's made up of collagen fibers that are kind of looped over like this. It's got cells and it's got other molecules that really all in all help protect the cartilage and give it its properties. And the really interesting thing is that the cartilage does not have a blood supply and it's got no nerve supply. And that's why protecting it is really important, because if you were to damage the meniscus, then there's very little capacity for it to heal. And this is really what happens with osteoarthritis. Commonly, there are micro injuries, so very minor injuries, but they can happen on a repetitive basis. So you gradually get some wear and tear of this, what looks like normal cartilage. But over time, that can become more severe, where the cartilage starts to blister, it starts to peel away, or it can just wear away and disintegrate. So you get the underlying bone exposed, and that's severe osteoarthritis. So those are diagrams. Here you can see what happens in the actual photographs of the knee during keyhole surgery. So again, normal looking cartilage here on the left, and then in the middle you've got moderate wear and tear of the cartilage where it's all frayed, and the superficial or the surface area of the cartilage is becoming worn down to the point where it's progressed to become even worse, and it's getting down towards the underlying bone. And here you can see a bit of a crater in the cartilage as well. So eventually you can get to the point where you, rather than having cartilage bearing surfaces, you get bone grinding on bone. And that, as you can imagine, is a really painful condition. And the same pathology happens in the hip joint. So what are the causes of osteoarthritis? There are a number of different risk factors. Age, as we mentioned, is a common association. Females are more commonly affected. Obesity also is a common association, and that's really because of the forces that pass across the knee joint. Over time, that can cause more wear and tear. Joint injuries, so people that are involved with sports can sustain injuries. This is a particularly bad ligament injury, but even once that initial ligament injury has been dealt with either surgically or with bracing, it's quite possible and likely that over the course of many years, high impact sporting activities like this can result in osteoarthritis. Repetitive, relatively minor stresses can also cause arthritis. So people who have manual work, or laborers like in this photograph, over the course of many years can develop wear and tear of the joints. And obviously there's a hereditary component, so genetic element to the cause of osteoarthritis. We commonly see patients who come to us saying, you know, they've got arthritis because their mother or their sister all have arthritis in their knees and hips. So it can be a number of different factors that influence the condition. In terms of the signs and symptoms, most patients suffering with osteoarthritis would typically complain of pain, and that's usually worse with activity. It's especially worse towards the end of the day. When it gets particularly severe, it can be worse, or it can be present even when the patients are at rest or in bed at night time. It can disturb their sleep. With the knee, typical symptoms are where the pain is worse with stair climbing or crouching, kneeling, those kind of activities become difficult. And with the hip, the classical features are where the pain is aggravated by twisting and bending the hip at the same time. So things like putting on shoes and socks can be difficult on that side, or cutting toenails. Getting in and out of a car can be painful too. Stiffness is a really common feature of osteoarthritis mentioned, and that again gradually can get worse with time. So can swelling. And then the other feature is a creaking noise, or what we call crepitus. And that really happens, as you can imagine, because of that irregular surface, often of the bony surface grinding on bone. And it can get to the point where even other people in the room can hear that happening. You may have experienced it yourself. But over time, if the arthritis isn't dealt with, then you can gradually see a reduction in mobility. Patients tend not to go out as much. They can't go on their long walks that they used to. They're unable to walk the dog. And eventually, it can even lead to a bigger reduction in function. So even their standard activities around the house can suffer. So they can't go up the stairs, they can't do their washing, they can't kneel down to a low shelf. There's a spectrum of symptoms here, from mild pain and stiffness to something a lot more substantial, where it's affecting all aspects of daily life. So how do we diagnose it or confirm the diagnosis? Often the history of the patients and what they tell us can essentially tell us what's going on. X-rays are the most common way we diagnose it, and you can see on the top left here an X-ray of the knee, and this is a relatively normal knee. We can see that because there's a joint space or an apparent space between the bones, and that's not really a space, it's just where the cartilage fills that gap. So there's nice healthy cartilage there. But on the right hand side, that cartilage has worn down completely, and there's osteoarthritis there, so the point where there's bone on bone arthritis. MRI scans can occasionally be used for osteoarthritis. You can see these images here. And this is helpful for us if we want to know exactly where the osteoarthritis is, if it's a bit more localized than widespread. Or if it can also show us other pathologies, like having loose pieces of bone floating around, it can tell us that. But also, just out of interest here, it shows us what happens to the bone itself. So there's some localized arthritis here where the black arrow is. But the surrounding bone here, which is the dark gray on one side and the dark gray on the other side, the bone immediately surrounding the area of arthritis, you can see is lit up with this high signal. And that really is like a bruising within the bone, directly as a result of the cartilage problem. Occasionally we can do ultrasound scan, and we can also use injections as well to be used as a diagnosis. So, for example, if patients have arthritis affecting their knees and their hips and their spine, and they've got pain in a number of different places, it can be difficult to hone in on exactly where the main problem is. So we sometimes use an injection, not as a treatment in that situation, but as a test where we put some local anesthetic in with or without steroid. And if, even for a short while, the symptoms are relieved, then we know that the main problem is arising from that particular joint. This is the X-ray of a pelvis, which shows the left hip on the left, also on the right-hand side of the image, and on the left-hand side of the image, it's the right hip. And you can see in the normal hip on the right-hand side of the screen, the ball and socket joint is looking relatively healthy. There's a joint space all the way around the ball, which represents good cartilage. But on the right hip over here, the ball and socket isn't as healthy. The joint space is obliterated over here. It's narrowed significantly to the point where there's probably bone rubbing on bone, and that has evidence of severe osteoarthritis. There's some other features that we look out for associated with osteoarthritis that include small cysts in the bone, and that again is a very common feature, but also cause sclerosis, and that just means a whitening or thickening locally of the bone around the area of arthritis. So obviously we've heard osteoarthritis is a really common condition, and it's a significant problem in the UK, but it's become a particularly big problem as a result of the pandemic. So for the last year and a half or more, we've all had major impacts on our lives and our work and our health, in some cases, due to the COVID pandemic. But for osteoarthritis patients, it's been a particularly bad problem. Some patients have been lucky enough to use the outdoors and do more exercise, but those patients that relied on swimming pools or gyms to get their activity, get their exercise, or physiotherapists, well, all that came to a stop largely. And so a lot of patients found that their joints became more stiff, more painful, they, they gained weight, and it was therefore a vicious cycle. Things became even worse. To add to the problems, we, for many months, had to stop operating. We lost our theatre space, we lost our staff around theatre, so we couldn't do our normal procedures like hip replacements, knee replacements, etc. And so there's a huge backlog of more than 5 million cases in the NHS that needs to be sorted over time. But it's also the outpatient facilities that have suffered as well. So even now, we've been back with operating for a few months, but we're not able to do as many cases as we'd like because of the extra processes that are in place in terms of extra swabs, extra isolation, extra cleaning between theatre cases, and also in clinic. The space in our clinics or waiting areas has effectively reduced because of social distancing. So we're not seeing quite as many patients as we'd like. Physiotherapy, as I said, has suffered as well. And the other factor that's played a role in the first half of the pandemic was the use of steroids. So steroid injections, particularly for the knee joint, are a fairly common type of treatment for many patients. And many GPs were giving them for years, and so were we in our clinics for some patients. But there was some advice to stop steroid use because, if at all possible, because there was a fear that if you were unlucky enough to get COVID-19, then the steroids might reduce your immune response and therefore make you more unwell with it. So there was some national guidance about avoiding it, but now that the majority of patients are vaccinated and we've seen that the risks are probably less than we feared, we started to use those once again. So the treatment of osteoarthritis depends on a number of factors, as you can imagine. It depends on the severity of the pain and the stiffness, the effect on daily life of patients, but also their functional demands. And patients do vary in terms of their expectations. So, for example, you can see at the bottom left, this patient has mild dementia. He lives in a care home, and all he really needs to do or wants to do is get from his bed to the chair and potter around the home. And so for him, a major operation is probably not appropriate. Whereas this patient on the right, he's a bit younger, he's active, he wants to remain active, but the knee pain is interfering with that. He's working, and so for him, something that is going to provide a more definitive management option, like an operation, may be more appropriate. As I mentioned, age does play a factor. Osteoarthritis is commonly seen in older patients, so age per se is not necessarily a barrier to, or high age is not a barrier to surgery. However, as you get into your 80s and 90s, then there is less physiological reserve, and we definitely take that into account. But we see patients that are potentially very fit and well for their age, into their 80s and occasionally into their 90s, in which case an operation might be the right thing for them. Going hand in hand with that is comorbidities. So other health problems, so heart disease, diabetes, previous history of strokes, these kind of things all kind of help make us come together with a plan for the patients. And if you have multiple other health issues, then again, a major operation may not be the right thing for you. But sometimes deformity can be a factor for us in terms of making the decision for an operation or advising an operation. This patient, for instance, here has a severe deformity, a knock-knee deformity. And if we left her without an operation, there's a chance that her osteoarthritis deteriorates, but also the deformity rapidly can deteriorate to the point where the structures around the knee, like the ligaments I was talking about, can tear and rupture. And eventually that might lead to the need for a much more complex operation with high risk. So that would be a case where I would advise an operation earlier rather than later. So what can you do to help yourself if you've got osteoarthritis? Well, for some patients, like those with mild osteoarthritis or those with low functional demands, those that are much younger in age, or those that are higher risk of an operation, the non-operative management strategies should be the mainstay of treatment. And exercise and physiotherapy are the real main ones to focus on. So some exercises are designed to improve your range of motion in the knees. So as we said, stiffness can be a real problem if you don't use the full range of movement. So exercise is specifically designed to push the boundaries of the range of motion are really important. But also exercises to build the strength of the muscles around the knee are key as well. What happens is if you don't use your muscles, they become weaker and they waste away. And weak muscles, we know, or fatigue muscles become a source of pain as well. So not only do you have a painful joint, but you have painful thigh muscles and calf muscles because they're so weak and they can't cope with the load that's required. So having physiotherapy, doing exercises on a regular basis to build this strength is really important. And if you're not familiar with exercises and you want some encouragement, then GPs should be able to refer you into really useful programs like Escape Pain, which is a proven exercise program available nationally. And it's run by physiotherapists as a group session. And it's designed to help improve pain, mobility and function. So it's definitely something that you should look into as a first line treatment. But along with physiotherapy and other exercises, activity and lifestyle modification is really important. I touched on the stresses that occur around the joints, particularly when there's already some damage. And remember that MRI scan image that I showed you, the bones around the area wear and tear really feel the pain, because you surprisingly do have nerve cells within the bone itself. So reducing any activities to reduce the stresses that pass across the joints can help your pain. It won't reverse the arthritis. Unfortunately, the cartilage damage is permanent, but your symptoms can actually improve. So making changes to your lifestyle, do more exercise to lose weight, changing your diet, all can help lose weight and therefore help reduce your pain. Reducing impact as well has the same effect. So if you're running or if you're doing high impact activities, if you prefer to go on long walks on irregular surfaces like fell walking or in the hills, then again, that can make your symptoms worse, particularly at the end of a long walk. So trying to reduce those forces by using things like Nordic poles, these walking poles, can also help share that load and reduce your symptoms. Focusing on other low impact activities like swimming and cycling are particularly recommended. And I tend to recommend having an exercise bike, especially to most patients, because it's something that's there in the house eventually. It means the weather can't influence whether you decide to go out or not. You can sit and watch TV as you're exercising. It's burning calories, it's strengthening your muscles, it keeps the joint mobile, and it's not it's a low weight bearing activity, so no impact. In terms of other non-operative management strategies, well, there's medications, and most people that have osteoarthritis have tried some form of medication. We'll all be familiar with paracetamol, but there are some other medications which are stronger ones. Sometimes they need prescriptions by a GP, like codeine or tramadol, particularly the higher doses. But obviously, you don't want to be on these long term, as there is problems with dependence on these. Anti-inflammatories can be helpful. So again, you need to check with your GP to make sure you're safe to take them, because they can interact with other medications, or can give you an upset stomach, or can affect your kidneys. But there are cream versions of anti-inflammatories like Voltarol cream or I Believe gel, which have been shown to be effective and actually recommended by NICE. So if you haven't tried that, then that's definitely something worth doing on a regular basis. And again, having that localized cream means that there's much less chance of being affected, of suffering the side effects. Another cream option is capsaicin or chili extract cream, which again is recommended by NICE. It used to be available on prescription some years ago, but it should be available now in most pharmacies. So again, worth considering that. For some people who have symptoms of the knee giving way, as well as their arthritis, or some people who have minor deformities and are keen to remain active with various sports and exercise, then wearing braces like the ones shown here or a sleeve around the knee can provide just enough stability to remain active. Some patients have other deformities. For example, they might have flat feet or problems with their toes, in which case seeing an orthotist or a podiatrist or getting some off-the-shelf insoles can help correct those minor deformities and help you walk better, and therefore reduce the stresses that pass across the knee or the hip. Some patients I see take some visco supplements in the form of tablets. And they include things like glucosamine or chondroitin sulfate, which you may have heard of. These medications are technically actually supplements. They're not medications. They are supplements that don't have side effects. And they're thought to help the health of the cartilage. But unfortunately, there's no strong clinical evidence that supports their use. But the theory is there, and actually we see a fair number of patients that get some benefit. So apart from the cost involved, there isn't really a downside. So if you want to give that a go, you can. If it works, carry on. If it doesn't work, then I would stop. So how can we as health professionals or orthopedic surgeons help you with osteoarthritis? Well, the first step to consider, if it's appropriate, and that's usually in mild and moderate disease, occasionally in severe disease, is the injectable options. And one of those commonly, you might be commonly familiar with, steroids. This has been shown to be effective for most patients for around 3 or 4 months. It might be a bit less, it might be a bit more than that. Typically, it's probably a bit more effective in knee osteoarthritis than in hips. And in terms of side effects, very few side effects, a tiny risk of infection. There is some theoretical evidence to suggest that it can cause cartilage softening. But one thing we do notice is that after several injections or several years of having injections, the effectiveness of a steroid injection does start to reduce in terms of the time benefit. Another injection type is hyaluronic acid. So hyaluronic acid is a normal constituent of cartilage. So the theory there is as the cartilage is degraded, these normal constituents are lost. And so therefore it may help that health of the cartilage. But it's actually thought that the main benefit is from the fact that the injection is out of a thick viscous fluid. And so lubrication is probably the main way it has its benefits there. And here we often see patients that have got wear and tear in their younger ages, often footballers at the end of their career or retired footballers often go for this option. It can give 6 months or more of improvement, but unfortunately it's not available on the NHS. And there is a small chance of having a flare type reaction or an inflammatory type reaction to this. It's a really rare condition which I've not seen. PRP or platelet-rich plasma is another form of injection therapy. It's actually been around as a treatment overall in medicine for about half a century, but in different uses. In orthopedics, it's actually been around for a lot less than that, probably up to 10 years. And knee osteoarthritis is one of the main potential uses of it. And PRP is where we take your blood sample and we spin it in a centrifuge and take a portion of that blood sample, which is rich in platelet cells. Now, platelet cells are from your bone marrow, and they are involved with any kind of tissue healing process or any injury to any part of the body. So when these cells are injected into an area of damage, it's thought that they help reduce damage to the area, they help start a healing kind of process. But the main effect is thought to be through an anti-inflammatory effect. And the studies that we have suggest that the length or the duration of the benefits of PRP seem to last significantly longer than the other two injections. But unfortunately, for a lot of people, it's still not available on the NHS. In terms of side effects, it's your own blood product, so there's no risk of infection or minimal risk of infection. As I said, the use of it is gradually increasing. So moving on to surgical options, well, this is for keyhole surgery is for a defined group of people. It's not always appropriate for osteoarthritis. But for patients with knee arthritis who also have, for example, a meniscal tear, so if you remember what the normal meniscus looks like, and this is a degenerative tear, so it's a tear in multiple areas. You can see that's not a healthy meniscus, it's not repairable, and in that situation, keyhole surgery to trim that torn meniscus will be of benefit. Likewise, surgery to remove a loose piece of cartilage or bone can be of benefit. And this is how we perform the keyhole surgery, using two little portals in the knee with our camera and instruments, and we can do various procedures using that system. The next step is joint replacement, and that's reserved for those patients with severe symptoms and severe disease. It's actually a highly successful operation, so knee and hip replacements are amongst the top three most successful operations all of medicine has to offer. And in the UK, we perform around about 160,000 of these joint replacements. The average age is patients in their 70s, and most people can expect their joint replacements in their knee and the hip to last over 20 years. And here's just some images of what knee replacements look like. So you can see on the left-hand side x-rays of the knee over here, and you can see on the inner side of the knee is where most of the wear and tear is, this narrowing of the joint space. And that's why this patient's had a partial knee replacement. So we resurface the end of the thigh bone and the top of the shin bone here, but just on one half of the knee. We leave the other half because it's relatively intact. On this right-hand side, we've got a total knee replacement in place, and that's because the wear and tear was more widespread. And you can see how the knee replacement is here on the photograph, with metal components on either side and a specialized plastic bearing surface, polyethylene in between. And really, a knee replacement is a bit of a misnomer. A lot of people just imagine with a knee replacement, we cut the knee out and we replace it completely. But as you can see from this image, this x-ray from the side, is actually a resurfacing procedure. We take away in a measured way the worn bearing, the worn surfaces of the end of the thigh bone and the top of the shin bone with particular measurements and angles and jigs that we use. And then we apply an appropriately sized component. But you can see how most of that bone is still intact, and the ligaments surrounding the knee on either side are intact. We do have to take one central ligament away typically, but sometimes we take the other cruciate ligament as well away too. This is a total hip replacement. You can see on the left-hand side of this patient's pelvis. We can use a number of different types of materials, but essentially we're replacing that ball and socket joint in this case. The sockets can be made of plastic or metal. It can be cemented in, or it can be left in with an uncemented technique. The bearing surfaces can be plastic or even made of ceramic also. So in summary, knee and hip osteoarthritis is a common and sometimes debilitating condition. There's a number of different risk factors involved, including obesity, injury, inactivity. The lockdowns of the last 18 months have really made matters worse for many patients. And the treatment of it is reliant on a multifaceted approach. So making lifestyle changes, losing weight, exercising, but doing the right forms of exercise, using medications if appropriate, considering injections, and then really reserving surgery for the most severe forms of disease. Thank you very much for listening. Bye.
Thank you very much, Mr. Sisodia, for a very excellent presentation and a whistle-stop to joint surgery. There are loads and loads of questions, and we only got about 15 minutes. So I've divided them into little groups to ask each one of you. So if you can spend maybe 1 or 2 minutes on each, that would be perfect. The first question was, should I wait as long as I can before having joint replacement? Should I really wait till I can do no more before having a knee replacement?
So it depends. If you reach the point where it's affecting your life, your daily activities, if painkillers are no longer useful, if you're lying in bed at night and you've got pain, then that essentially means that you've got severe disease and you probably need to see a surgeon to be considered for a joint replacement. If you were to leave it much longer than that, then your general health can suffer. You can develop contractures. You can develop more severe forms of disease, which eventually might need an even more complicated operation. But obviously, if you're young, so below the age of 60, my advice would be to try and wait as long as possible. Hold on to your joint as long as you can. Knee replacements, hip replacements are good, but they don't last forever. And so we need to take that into account. When a knee replacement fails or wears out eventually after many years, then the solution to that is a revision knee replacement, which is a much bigger operation. So age definitely plays a part in it, and also how much is impacting your life.
Great, that's very helpful. And once the orthopedic surgeons have recommended a joint replacement, it probably is not very sensible to wait any longer, is it? Because they consider all sorts of options before offering the option.
Exactly, yeah. We offer making a decision for a joint replacement is definitely a joint decision, mind the problem. But it's if you find an orthopedic surgeon has offered you a knee replacement or hip replacement, certainly in my practice, it essentially means that I think it's appropriate for you. If I feel it's not appropriate for you, I wouldn't offer you that operation. So I think that's generally, you can take that as an indication that it's probably the right treatment for you.
You did mention that you've done lots of these operations and the complication rate is very low and all that. Can you give us some idea to relieve our anxiety and worry about joint operation? What sort of waiting time there is, what success rate is, and what do you do in recovery, and how much help you might require at home, and how quickly can one start walking and doing things like that?
Okay. So a few things there.
Hundreds of questions there for you.
Yeah. So in terms of how long the waiting lists are, on the NHS, obviously it depends on which hospital, which region you are in the UK. But for example, in my practice in the NHS, we're looking at well above 6 months, if not closer to 8 months. Some patients are waiting in other practices for a year or more. So it's variable, and it can be really frustrating. So my advice is, if you know you need something doing, then seek attention sooner rather than later. In terms of the success rates, as I said, it's a highly successful operation. Hip replacements in particular, 98% of patients can expect it to last at least 15 years. So it's not the case that at 15 years the hip replacement fails. It's probably true, that the vast majority lasts at least 20 years, if not longer. Knee replacements, that figure is slightly smaller, closer to 95% can expect to last at least 15 years. There are some risks. So risks include bleeding, blood clots to the legs or the lungs, a tiny risk of infection, risk of loosening. So as I said, the way joint replacements might wear out can result in loosening, and that's when you might need further surgery. But as I said, most patients can expect it to last 15 years. In terms of inpatient stay, typically in most good places where you have good physiotherapy, occupational therapy, and nursing, then you can expect to be in hospital for 2 days, and then you have lots of exercises that are given to you to perform. And with a hip replacement, it's actually quite easy going for a patient. You can have the operation, you'll have some pain, but you typically don't have to do too much in the way of exercise. You will have to take some precautions to try and minimize the risk of dislocation. It's a very low risk, but you can minimize that even further. But with a knee replacement, there's a lot of responsibility on the patient. So it's definitely a 50-50 kind of relationship. As a surgeon, I will do the operation, but I can't then do the rehab for you. And there's a real requirement for patients to work hard at the exercises. And it's not that uncommon that before in my clinic, I see a patient and I feel that they are not going to be able to cope with the rigors of rehabilitation. If they are deconditioned, if they're weak, then I may say that an operation is not appropriate, because they would actually be made worse by a major operation. So it's not to be considered as a miracle cure. There's definitely a lot of work with knee replacement that patients have to do afterwards. Yeah.
2 or 3 days after the hospital treatment, when they go home, are they able to manage stairs and sit in the chair and things like that, or how limited is it? And if you can tell us that about the hip and the knee.
Yeah, sure. Yeah. So for the hip, you have at least 6 weeks where you'll be expected to sit in a high chair to, again, minimize the risk of dislocation. So your physiotherapist and your occupational therapist will go through that with you. They'll provide you with fitments at home to help you with that, stair rails and various other things if needed. During the inpatient stay, they will also go through these precautions that you need to take specifically for a hip replacement patients. And in terms of walking and stuff, you'll be expected to walk on the first day or even the same day as the operation. In our practice, sometimes we find the patients are walking on it. In terms of stairs, most units will be, physiotherapists will be taking patients through stair climbing exercises as an inpatient. So on day 1 or day 2 after the operation, and typically they will let you home once you can manage a few steps. So yeah, you go home pretty functional, albeit with either 2 sticks or a Zimmer frame. You will have to stick to the exercise and the precautions. You may need some extra facilities at home, but that's all planned in advance. In terms of when you get rid of your sticks and things like that, for a knee replacement, most patients come to my 6-week follow-up clinic, usually either with 1 stick or no sticks, just depends on how their function was before. Hip replacements, likewise, they're often quite functional at 6 weeks. Most patients should be driving by 6 weeks as well. So that is often a turning point for most patients. With knee replacement, so again, worth bearing in mind, it's a lot more painful a procedure than a hip replacement. So that pain can be present for several weeks, even months afterwards. Likewise, swelling, it can be quite an issue for patients. But again, 6, 7, 8 weeks is often a turning point. And then the first 3, 4 months of the rehabilitation is a window of opportunity where patients have to work really hard with exercises. If they wait too long, then actually that window closes and they're stuck with that range of motion.
What about lying in bed and things like that, and using the toilets and things like that? How does one get on that?
Yeah, so again, for the toilet, for hip replacement, you'll be given an additional fitment that fits on top of the toilet to make it higher and to, again, minimize the risk of dislocation. Lying in bed after a knee replacement there aren't really any restrictions, but after hip replacement, you'll be expected to lie on your back for at least 6 weeks, if not longer. And thereafter, if you want to lie on your side, you should be lying with a pillow or cushion between your knees. Again, all designed to try and minimize the risk of dislocation.
In my practice, all the people with joint replacement have said that the chronic pain improves markedly after joint replacement. Can you confirm that and tell us a bit more so that we feel a bit better about having the operation?
Yeah, so, I have to say it is a really successful operation, but when you compare knee replacements and hip replacements, the knee replacement is a bigger joint, it's more superficial, so you can imagine the soft tissues and the nerves around your knee are affected probably a bit more. So pain is a bigger issue potentially. And I advise patients, based on the literature that we have globally, that about 15% of patients after a total knee replacement, that's despite doing everything well surgically, can still have some degree of pain afterwards. And that might just be a minor amount of pain, or it might be something more severe, substantial, and that can be long-term. So about 15% can have some degree of pain. The vast majority still do really well. Those patients that have a history of really severe, chronic, unremitting pain beforehand for many, many years, patients that have aspects of nerve pain or chronic back pain as well as their knee pain, for instance, we identify as being at slightly higher risk of having much higher levels of pain afterwards. So really important to get on top of the pain beforehand, get yourself into a good regime of exercise, so you've kind of prepared yourself for a major operation, which will almost certainly raise your pain levels. So it's something that has to be taken with caution when you've got these high levels of chronic pain.
Do some people have more than one joint replacement? Does it make their life much better, or is it?
Yeah, so as you can imagine, we commonly see patients with bilateral problems, so both knees affected, both hips affected, or all four of the main joints there affected. Years ago, people used to do simultaneous joint replacements, but we found that actually over the years, there's real risks of significant blood loss, and therefore risks to your heart and need for blood transfusion and various associated risks with that. So our recommendations, if you have severe joint disease in more than one joint, for example, both your knees, then to have a staged procedure. So have one joint done and perhaps 2 to 3 months later, ideally, have the other one done. Sometimes if you have severe disease and you've developed contractures, so your knee does not fully straighten, and that can affect both knees, patients can walk with a kind of a stooped gait, and they walk with flexed knees. If we do a knee replacement, part of that operation is to straighten the knee, to improve the alignment as well as improve the function of the patient and the pain. So when we improve the alignment and straighten the knee, unfortunately, the other knee has a similar previous contracture, and it might actually prevent the patient from getting on with their rehab and cause a contracture to develop again. So in those circumstances, we'd strongly recommend having an operation sooner rather than later on the other side.
Thank you very much. We haven't got that much time left, but I'm going to ask you 2 more questions. What are what you call red flag symptoms that people should look out for that will tell you this person is not going to do anything else apart from a replacement of the joint? Can you give some indication about what sort of symptoms or other things that we need to look out for?
In terms of indications for surgery?
Surgery, yeah.
So for the hip and the knee, actually, one of the typical questions we ask is, do you have pain at night? Is it disturbing your sleep? So if that's the case, then that means that they've got severe pain at rest. So even without weight bearing, then that's one of the things. Pain relief. So if the patients are on the strongest kinds of painkillers, for example, morphine patches, high doses of codeine for a long time, they've seen the pain, they've tried everything possible, then obviously they need something doing, and an operation will be appropriate at that stage. So it's kind of the history of the pain and function that's key.
Can I ask just last question? And this is your top tip for preventing joint damage in everyone. What should we do?
Well, it's difficult to always prevent damage. However, if you're doing sports, if you're a keen sports person, then always have frequent rests, do warm-ups, avoid frequent or high impact activities. So there's always a bit of confusion about things like running, for instance. People say, oh, should we run or shouldn't we run? Generally speaking, if you have a very healthy joint without any damage, then it's fine to run. Just wear good footwear, try and run on softer surfaces rather than hard concrete. But if you have already established some wear and tear, then running a marathon every week is going to make matters worse. So I would say look after your knee, look after your joints, avoid high impact if you've got damage, and do lots of warm-ups and do stretching exercises as well.
So mobilize yourself as much as you can within reason.
Absolutely.
Thank you very much, Mr. Sisodia, for stepping in at the 11th hour and for the excellent talk that you gave. There were hundreds and hundreds of questions, so that suggests that it was very well listened to and very relevant. And it was a real pleasure for me to learn things from there as well and ask questions. So thank you very much indeed. On the 5th of October, we are talking about the story of vaccination. That's our next session. I'd like to thank Gayatri Ben and the whole of the IT team for their effort in putting this program on. And thank you all for listening and participating. That is really appreciated. Above all, I'd like to thank our beloved Lord, without whose grace nothing would ever happen. Sai Ram, all of you. Thank you very much for listening.